Thank you for joining us for Conversations and Cases in Oncology, practice-changing updates in systemic treatment of advanced hepatocellular carcinoma. During this segment, we will be discussing case scenarios to integrate recent treatment progress. I'm Dr. Rashna Shroff, Professor of Medicine and Chief of the Division of Hematology Oncology at the University of Arizona Cancer Center. And I'm joined today by my two colleagues, Dr. Adam Burgoyne and Dr. Mark Yarshoin. So we've been discussing all of the incredible progress that we have been making in the treatments in the frontline setting, in the second line and beyond, as well as the perioperative setting. And so I thought the best way to kind of approach how we do this is to come up with a case and have you guys help me figure out how we would approach these patients. Why don't we start with a 65-year-old patient who presents with advanced hepatocellular carcinoma, unresectable. Patient has no known comorbidities. His child Pu-A has really well-preserved and well-compensated, well-preserved liver function and compensated cirrhosis, and has not yet received treatment and is sitting in your clinic. So why don't we first start with where we could consider starting frontline therapy in this patient and what types of treatments you would consider and what type of workup would be needed to consider specific treatments. Adam, what are your thoughts?
Well, I think we know that kind of one key decision point in our triage of our patients with advanced HCC is it sounds like this patient's in pretty good shape and their liver is functioning well. But even in the setting of patients that have reasonably good synthetic function, we know that we can sometimes see portal hypertension, particularly in patients that have evidence of vascular invasion. And from a safety perspective, we always want to make sure that we are evaluating patients appropriately. So engaging with your favorite local hepatologist and getting someone set up with an upper endoscopy is important for assessing for the presence or absence of esophageal varices, assessing their bleeding risk, because we know that that was mandated in the IMbrave 150 study for patients that were being considered for combination therapy with atezolizumab plus bevacizumab. And I think helps us as kind of a starting point on kind of where to go.
Great. Mark, is there anything else that you think would be necessary outside of an EGD to assess for varices that would be necessary to really do prior to making that decision tree in terms of treatment? And if not, what are your thoughts, assuming that there was an EGD that did not show any concern for varices and at risk for bleeding? What would you start this patient on?
Yeah, this is a fun case because we really have an open slate here. I mean, this is a patient who can get whatever we want. For me, a lot is driven by the tumor burden. I mean, if this is a patient who's symptomatic, has impending liver failure from just massive tumor burden, just a lot of disease where a response would be helpful, probably this is a patient that I would lean towards atezo-bev because, again, it's challenging to do these cross-trial comparisons, but the data would seem to suggest that the response rate might be higher for atezo-bev. This is a patient who has very indolent disease, not a lot of disease burden, where a response would be transformative. But if they didn't respond, they're definitely going to make it to second and third line therapy. I think durvalumab would also be totally reasonable here. I don't think there's a right answer, but I think the two preferred regimens in this case would be atezo-bev and durvalumab. Either is appropriate.
And what about, in these kind of little bit more complicated situations, somebody with an active autoimmune disease or some sort of contraindication to steroids? I mean, Adam, what is your go-to in somebody in whom you have to have pause about giving immunotherapy?
Yeah, it doesn't happen as frequently as we might think, but it does happen. I had a patient that I saw in clinic last week that had a sort of undiagnosed autoimmune skin condition. We were a little bit worried. He actually already received some immunotherapy as an outpatient from a referring provider, and his skin disease had flared a little bit. So I think when you're evaluating that person and deciding what's best for them, sometimes immunotherapy isn't our best option because we certainly do see these flares of autoimmune conditions. They can be problematic depending on what autoimmune issue we're dealing with. So I do typically reach for a TKI in that situation. And I think just kind of evaluating our current data sets that we have available in 2024, lenvatinib tends to be sort of our best bet in terms of response, non-inferior to sorafenib in the frontline setting, slightly, actually relatively substantially higher response rates that we can see, again, if we're looking for response. And then a safety profile that is just a little bit more favorable than sorafenib. Less hand-foot syndrome with the trade-off of a little bit more hypertension and proteinuria and hypothyroidism. But as clinicians, as most of us are internists by training, those are problems that we can fix that tend to be relatively silent. Managing blood pressure, starting people on thyroid medicines, whereas really significant skin toxicity, bad hand-foot, weeping, peeling, blisters. Those are hard things for patients to come back from and can be difficult problems to manage.
And just wearing our hats as clinical trialists and being interested in the drug development space in HCC, Mark, and somebody who's a newly diagnosed, like you said, kind of clean slate ideal patient, are there certain clinical trials that you would consider this patient for that you know of that you think are the ones to keep our eye on?
Yeah, I mean, I'm really of the opinion that whenever a trial is available, it should always be considered. We've just seen how much progress we've made in HCC over a short amount of time, and that would only be possible because of clinical trials. And I have patients alive today who were on the Himalaya trial who got durvatremi and have received nothing else since that time. So, trials can be transformative for patients. We have a lot of trials now of triplet therapy. These are trials building on, in the most part, the combination of VEGF, PD-1 plus something else, whether it's TIGIT or LAG-3 or something else. I think if that were an option, I would immediately at least discuss it with the patient. There are patients who are interested in trials, there are patients who aren't, but as a community, we should definitely raise awareness of trials and look for them when possible.
I think it's also challenging with this patient population in HCC as well. And, as much as we love to offer clinical trials to every patient with cancer when feasible, we know that, in real world practice, the majority of our HCC patients, for one reason or another, end up not being clinical trial candidates. So whenever we do have one of these, really fit, really motivated, good liver function patients, that's a good clinical trial candidate, both for that patient and really for the evolution of clinical research. I totally agree. We should always try to promote that.
So let's say that this patient was given atezo-bev and had a best response of stable disease, but was able to stay on that regimen for 8 months, and now is developing new intrahepatic lesions and is progressing, but is still doing well, feels well, and has, again, still Child-Pugh A, and is able to continue on to second-line therapy. I know we kind of discussed some of these options previously, but, what would be your treatment next for this person, Mark?
Yeah, I think, my default second-line therapy in that case would be a TKI, either a frontline TKI like lenvatinib or a traditional second-line TKI like cabozantinib. Both are completely reasonable. I don't think there's a right answer.
Do you have a tendency, Adam, to sequence through them? Say you start with lenvatinib and, they, again, have some sort of at least response or stable disease for some time and then progress. Do you eventually give them cabozantinib? Do you try to make sure that they see all of these different TKIs? What's your approach there?
I think it's a great question, and to punt the question a little bit, it does become very patient specific. I think each line of therapy becomes a little bit more nuanced, not just in trying to evaluate the data, but what's happening with that patient. What happened with the TKI? Was it hard for them to tolerate? Did they have a lot of side effects? Is it now time to go back to thinking about moving to IO and bringing back in perhaps dual immune checkpoint blockade if they had atezo-bev in the front line? Or did they have some immune-related adverse event in the front line, and that's why they stopped their checkpoint inhibitor? So now we're really kind of left with TKIs, and then we're thinking about sequencing through lenvatinib to perhaps cabozantinib. But even in the absence of any of those things, as I think Mark said, there's no right answer here. We're kind of just trying to extrapolate data, use our best clinical judgment to offer what we think is best for that patient.
And when you are treating these patients in the front line with immunotherapy, Mark, do you have very specific to the point about safety and adverse events and monitoring? And, do you have a very specific approach in somebody who develops an IRAE? Is it specific to, the type of AE it is? I mean, what's your typical take in terms of helping these patients tolerate and continue on therapy?
Yeah, this is so tough, right? I think these are really case-by-case situations. I mean, if it's a skin rash, normally those are very easily addressed. If it's, myocarditis, it's a very different situation. So it's hard to provide, total generalities here, but Nevo-Ipi, in my experience, is toxic enough that if patients are not fantastic reporters of side effects, I do get a little bit nervous about it, and I tend to see them quite often, especially in that sort of 4 to 12 week window where the most IREs happen. I tend to see them even every 2 to 3 weeks in that time.
So let's take a different patient. Let's take a 75-year-old who actually does have significant comorbidities, still has, again, Child-Pugh, let's say A, maybe an early B, something a little bit more complicated, and does actually undergo an EGD and does have some varices that are a little bit concerning for giving Bev. Adam, is this somebody that you would think about STRIDE? You would think about the Himalaya approach? What would be your frontline approach in this type of a patient?
Absolutely. I mean, in my clinical practice, although for someone that doesn't have varices, both atezo-bev and STRIDE are acceptable choices. I do think in this circumstance where you're worried about bleeding risk, they do tend to reach for STRIDE the majority of those cases. It's something that's VEGF sparing. We don't worry as much about the bleeding risk. And it's something that, we can kind of hope for the best with efficacy for that patient, with not that we don't worry about safety. And, one point that I always like to stress as we're thinking about managing the whole patient is just because someone's not getting bevacizumab doesn't mean that they can't bleed. And we still need to make sure that people have ongoing engagement with their hepatologist. If they had varices that were banded, that, we're continuing to follow up those with serial EGDs and kind of not just forgetting about their bleeding risk just because we're thinking about their systemic therapy.
And, Mark, one question that I think we all get asked a lot is, in somebody who is Bev ineligible and say gets STRIDE and then gets Durva-Tremi up front, do you feel comfortable giving VEGF what are multi-targeting tyrosine kinase inhibitors, but do have a VEGF component to it? What would you do post Durva-Tremi in somebody that wasn't able to get Bev in the second line setting? What's your approach there?
Yeah, I generally do. I mean, before we had Bev and before we did EGDs on everyone, we were giving everyone, ramucirumab and not thinking too much about it. So I think I think we've become, maybe the pendulum's gone a little bit too far in our squeamishness of anti-VEGF agents. I feel pretty comfortable with them.
Yeah, and I think there is this difference between infusional monoclonal antibodies where you're kind of worried about the on-off effect versus TKIs that you can stop as needed.
Totally.
Yeah, absolutely. I feel the same way. I do agree, Mark. I say that all the time. I say, well, we were doing EGDs for our, cirrhotic patients, but we weren't necessarily doing them serially with alignment with the therapy of choice. And so a lot of these patients were getting lenvatinib and cabo and all these other drugs long before we started thinking like this. So I completely agree. Well, I think what these cases summarize is, as we've mentioned, is there has been a tremendous amount of progress in the space of treatment of advanced hepatocellular carcinoma, so much so that we can have a conversation and a dialogue and a debate about which treatment to use and in which line. And now we are actually able to have discussions related to what do we give in the second and third and fourth line, and do we use IO combinations or IO alone? And I think it's just a really new treatment landscape in the setting of this disease, which is just wonderful. But I think what we also know is that there's a lot of work to be done, and that the clinical trials that are ongoing, I think, will help us really set the stage, especially in, like we mentioned, a post-atezo-bev and Durva-Tremi world, to really understand what else can be added to it or considered as potential practice-changing regimens in comparison to atezo-bev and or Durva-Tremi. So I'd like to thank you again for joining us for this segment on discussing case scenarios to integrate recent treatment progress in HCC. Please be sure to click on the landing page for this activity to claim your continuing education credit, access supplemental slides, as well as other topic segments. Thank you very much for joining us.